This edition of the program, our discussion is on reproductive, maternal, and child health, the status in Nigeria, and what are we doing in the FCT to reduce the ugly statistics. So much talked about the 512 per 100,000 deaths, so much talked about the under 5 mortality, so much talked about the neonatal mortality. What are we doing to ensure that these statistics are reduced to the barest minimum? And so to do this, I have with me the country director, Rotary Action Group for Reproductive, Maternal and Child Health, Rotary RMCH. Of course, he's a popular man, Professor Emmanuel Irufadeju. Very good morning and welcome.
Good morning and thanks for having me.
Yeah. So let us start by looking at what we have in terms of RMCH in Nigeria.
Okay, thank you very much. The Rotary Action Group for Reproductive, Maternal and Child Health is an independent affiliate of Rotary International, made up of Rotarians and members of the public can join the Action Group. The Action Group is a group of experts in a specific area. We have many of them in Rotary. Our own Action Group is looking at how to improve maternal and child health all over the world. There are action groups for other things. There is action group for malaria, action group for AIDS prevention, and so on and so forth. And they are all under one umbrella in Rotary. I was a past chairman of this action group. I'm a co-founder of the action group, together with my colleagues Bob Lindsay in the United States and Robert Sinza in Germany. The three of us started it. And now it is a worldwide organization doing work essentially on improving maternal and child health in the country.
Yeah, so where are we now in terms of the ugly statistics? Is it getting better? Are they reducing? What do we have?
Well, in answering that question, let me go to a little bit of history and what we need to do and what we are doing to reduce these ugly statistics, as you call it. Rotary Foundation has been involved in maternal and child health, prevention of maternal death resulting from pregnancy and childbirth complications since 1995.
Quite a long time.
It's going to about 29 years. And I started with a colleague from Germany. We started very small in two local governments in Kaduna State. One of the aspects of reduction of maternal death is family planning, child spacing. And that's how we started. And the indicator that we are looking at is contraceptive prevalence rate. That is the number of women of childbearing age who are using contraceptives. When we started in those local government areas, they were 3% at that time. And we moved from 3% to 27% by year 2000. And since then,
within 5 years.
Within 5 years. And Rotary got interested and gave us a 3H grant at that time, Health, Hunger and Humanity, to push it further and do exactly the same thing that we are doing. What were we doing? We were doing 4 major steps. One is public awareness, creation of public awareness, because the public has to know a reproductive system in the body and how to prevent death and things like that. So public awareness campaign. We were doing capacity building of medical officers in the hospitals, primary care centers, and so on and so forth. And then we were doing contraceptive distribution. We were doing all kinds of contraceptive pills, the insertions, the injectables. We were distributing it in those areas. And of course, we were doing the institutional strengthening, given equipment. In fact, the first set of ultrasound in Ahmadu Bello University was donated by Rotary at that time. So those first steps, we repeated it for another 5 years. And the implication of that is that not only reducing the maternal death, by increasing the number of primary care centers where people can go, bringing primary care center closer to the people, and therefore they can have access. The government in those days created more primary care centers, and that's what we are seeing today. They are creating more primary care centers, and they are upgrading some of them. But the primary care centers are the ones that are close to the people. So they were increasing them, and by that, we were improving the number of women who are seeking health. Health-seeking ability of women became stronger. And that way, we were able to reduce the number of women, increase the number of women who are using contraceptives. Then in 2009, we started what is called quality assurance in obstetrics. That quality assurance was in 65 hospitals. It's looking at the quality of structure of the hospital. What does the hospital have? Are there shortages of buildings, with, theater for surgery?
What of human resource?
Human resources, all of those, the quality of structure. Then the quality of the process. You know, the process by which a woman, when they get pregnant in the community, how do they access the hospital? There are 3 delays that are very important. Delay at home before a woman takes a decision that I want to deliver in the hospital rather than at home. That's number 1 delay, which can be very risky and costly. Then when the woman finally decides she wants to use the facility, the distance between the home and the hospital is another delay. Delay in transportation, there may not be transportation, the road will be bad, there may not be enough funds. That's another problem. And then delay in the facility itself. When they get to the hospital, are there doctors present? Is there a room for her to deliver? Are there facilities to do surgery if there is emergency? Those are the 3 delays that causes that are risky delays that contributes to maternal death. And there are 3 conditions that are very critical. Postpartum hemorrhage, when a woman is bleeding during childbirth and after childbirth. The second is sepsis, and the third is eclampsia. Eclampsia is like having to do with pressure, what we call seizures during that period of time. All of these are preventable, but in order to prevent them, you have to present yourself at the facility to stop them from happening. We also have risky pregnancies. Pregnancy too early in life, 12, 13, 14 years of age, is very dangerous. Pregnancy that are happening at old age. After 35, 40, you know, it's not that, so it's not everybody that is predisposed to that condition. But it's good to avoid it because you don't know what will happen. If you are 40 years and you are getting pregnant, you are to be under intensive medical care to make sure that that pregnancy is successful. Okay.
So how were you able?
There are pregnancies that are too close, and there are pregnancies that are too many. All of those are predisposing women to death, and that is why what RMCH does in those projects that I've mentioned to reduce maternal, because we are counteracting those risky conditions. In 2013, when we did assessment of quality assurance in obstetrics, we discovered that by looking at those factors, ameliorating them, making them better, and by providing conditions for health, sanitation in the hospitals, we were able to demonstrate reduction in maternal death by 50%. This is published in peer-reviewed journals, and infant death by 15%. Professor Adiza Galadanchi in Kano and Professor Olada Koshitu were involved in this study that we did together to bring this result.
So how were you able to navigate that terrain and get them, buy into, of course, the method of reducing, maternal death?
Thank you.
Because it's a. I don't want to use the word volatile.
Yes.
I don't want to use the word religious, but you know that it's really a hard knock.
Very good question. When we finished that quality assurance in obstetrics, the federal government also started a program on maternal and perinatal death prevention. So we appealed to the federal government that we wanted to work with them because quality assurance and maternal and perinatal death surveillance and response is looking like the same thing. So in 2017, we started what is called MPCDSR, maternal perinatal child surveillance, child death surveillance and response, MPCDSR, maternal perinatal death surveillance and response. And that really did a lot of improvement into the system. It became a policy of the federal government. And the key issue that remained was how do we measure progress? If we are doing, we are preventing maternal death, perinatal death, child death, we are surveying it, and we are providing response. How do we measure? Those Rotary introduced an electronic platform. An electronic platform that can capture this death anywhere in the country. By just a tip of the finger on your computer, we brought an application and we trained medical record officers, we trained the M&E officers of the local government, and they are able to do this, put the data of any death that occurs in any hospital in the country, and they send the result to the state HMIS officer. That's the guy in charge of information management, and that guy sent it to the federal administrator. So we had a pool, and all this particular platform is able to analyze the result automatically, to provide reports and results automatically. So we did a lot of capacity building to make sure that we have entrenched that in all the secondary hospitals in Nigeria and all the tertiary hospitals in the country. So that system is there now. We can measure, we can notify. If a death occurs in any facility, it's immediate notification within 24 hours by the system. And this system, once it is notified at the community level or at the facility, it goes straight to the state, and the state sends it to the Federal Ministry of Health. Not only that, that platform has a capacity to review death of mothers. What has happened? Why did the woman die? What was the condition before she died? It's a review by the facility itself. And that review is also captured in the platform and sent to the federal. So by that way, we're able to know the causes of death and how to prevent it. We can target which hospital death is occurring, where is postpartum hemorrhage, where is eclampsia happening, where is sepsis happening in the country, where is preventable pregnancy, abortions, where is it happening in the country. Then it became, you can see it on the computer. So we took it to all the states, the commissioners, the permanent secretaries in the states, all have this platform through their HMIS officers.
Okay, let's look a bit of child mortality, which we know is also preventable using vaccine. What is happening in this area?
Well, child mortality, as you said, is preventable, especially under 5. There is what we call statutory immunizations. When a child is born, you are supposed to take immunizations at periodic intervals to prevent diseases like diphtheria, like infections, like malaria, especially malaria, uh, to prevent whooping cough and all of those things that affect children,
including pneumonia.
including pneumonia, so many of those type of conditions that children can have. The thing is that our people, especially in the community, do not access facility where the child will be tested and solutions can be provided for the ailment. So part of our responsibility is to make sure that families are accessing health facilities in the primary health care center, particularly, which is closer to them, and most of the attention there, most of the care is free by the government. And once they do that, you can see drastic reduction in cases. We don't want a case to become complicated and then you start referring to secondary hospitals and then you are required to pay a lot of money and all of this. And I'm happy I had a meeting with yesterday I had a meeting with, this is all by the way, I had a meeting with the presidential advisor to the President on Health, Mrs. Salma Anas Ibrahim. She told me that one of the key aspects the federal government is looking at now is to make sure that at least in every ward in the country, 2 health facilities are operative.
Functional.
Primary health care centers in every ward in the country. So we have 774 local governments, and every local government has at least 10 wards, at least minimum of 10 wards, and under the wards there are communities. So you can see that there is a lot of mobilization, especially at the grassroots level, to make sure that we fight the scourge of maternal and child death in the country. But the key is the maternal perinatal child death surveillance and response, MPCDSR, because that is the one that will be able to look at what is happening in the facilities and the communities and be able to report it in real-time data, not guess work, not estimation. The 512 death of mothers as a result of 100,000 live birth that you mentioned is an estimate. We need to get real-time data. What is the real-time data? And you know it's an average of the whole country. It doesn't mean that every part of the country is 512 dead by 100,000 live birth. There are places with more than that, and there are places with less than that. It's just an average. But we are able, because of that data, to concentrate in areas where there is intense need for support for prevention of maternal and child death in the country.
Yeah, a bit of a challenge. You know, when these commodities are provided, we hear issues of commodities looted. The reproductive health commodity, the barrier and all of that, the IUD. We discovered that the nurses loot it and sell. Or when you go to the hospital, they tell you you must pay, and they're supposed to be free to an extent. What is your monitoring mechanism against stealing of reproductive health commodity?
I'm not really aware of the stealing. Let's talk about how do we monitor what is sent to the
how it's used.
How is it being used? You are right that we are short of contraceptives. The federal government is trying to provide contraceptive, mainly through UNFPA. And Rotary International also supports in the provision of a contraceptive that is called LNGIUS, which is a combination of hormone and barrier that we have been distributing since 2013. There are other organizations also who are providing contraceptive. But what we are advocating is that the basic health care fund, which is supposed to take care of health issues amongst Nigerian community, should have substantial amount of money for procurement of contraceptives so that it will be enough. It's not enough. And as a matter of fact, women have preferences of contraceptives. Some like IUD, some like injectable, some like insertions. So if it doesn't have, if the facility does not have what she wants, she may not take an alternative. So again, that is important to make sure that all the classes of contraceptive are present at the community level. And we are trying so much to do that. Also, I must mention that there are some states that are supporting the federal government, in fact, to provide contraceptives. So everybody knows now that family planning by child spacing, giving gap between birth, not actually to be misconstrued with population control. It's nothing to do with population control. We are talking about health of women and children by spacing birth. So one birth is strong enough, the woman is strong enough, the child is strong enough before another birth. That's what we are talking about. You can have as many children as you want.
But you must maintain a regular gap.
We must maintain the gap to keep the woman in healthy condition. That's very important. And you find out that even these days with the economic condition, people are looking at it more sensitively now, that they are not having more than 2 or 3 children. In general, the family size is kind of reducing. I have not seen the new DHIS report, but I'm sure that report will indicate some kind of reduction in fertility rates.
So as we attempt to round up, I'd like you to speak to the public on the reason why they should embrace modern method of contraception and why they should take their children to health facility for immunization.
Thank you. Everything you have said, family planning, immunization, prevention of maternal and child death, attendant to antenatal clinic, postpartum, family planning, all come under safe motherhood in general. And I'm the chairman of the technical working group for safe motherhood in the country under the Federal Ministry of Health. And the director that is in charge of safe motherhood is Dr. Samuel Oyeniyi, whom we have been working with for the past 4 years. So they are always providing guidelines, innovations, improvement to ensure that, one, women attend antenatal clinics when they are pregnant so that they can see the pregnancy and assist them before childbirth. They want to make sure even after you have given birth, you have to also report at interval to the clinic to see what we call postpartum, after birth examination. We want to discourage delivery at home because you never know how a pregnancy will shape. It may become complicated, and the people who are delivering you at home, basically the traditional birth attendants, they don't have the technical instruments and sometimes skills to be able to deliver a baby successfully. And if you continue to persist to deliver a baby under those conditions, you have what we call prolonged labor. It can result into excessive bleeding, it can result to dead fetus, it can result in all kinds of conditions, including VVF, vesicular fistula. It can damage the channel for childbirth. So those are the things that we are working against. How are we working against them? As I said earlier, public awareness campaign. Our major work is to convince communities in the whole of Nigeria. Please, when your wife is pregnant, go to the clinic. When you have a newborn baby, take her to the clinic. Take him to the clinic. Let them give her, follow the immunization process that has been laid out. That's one. Number two, we are doing what is called outreach. Outreach is people who are not able to access facilities for whatever reason. Maybe it's a hard to reach area, or they don't have transportation, our team of community health extension workers can reach them in the home. And the beauty of this is that when you reach the home of a particular client, you are not only looking for, are you pregnant? Do you want to space children? Are you using contraceptive and all that? They will see children that are sickly with malnutrition, with malaria, and they can treat because they are community health extension workers. And you know the federal government has a policy that is called task shifting, task sharing, which means everything that a nurse can do, especially with related of women health and child health, contraceptive dispensation and so on, can be done by community health extension workers. They have been trained also, but we are continuing to train and retrain them. You know, training has no limit. We do training every time. We are making sure that we are upgrading our training, and we are assisting the government to upgrade primary care center. We have a program under our program for Together for Healthy Families in Nigeria. It's a new program now that is now we are trying to renovate selected facilities in the states where we are working, in Gombe, Nasarawa, Ekiti, and the FCT.
Are you going to do that?
We already started to do that through the Ministry of the state ministries of health, reproductive health coordinators in the state, and we have Rotary representatives in each of these states who have gone right to the facility that we are working in, and they have assessed the needs there, and we are trying to provide the needs in the next 1 month.
I must thank you so very much for your time with us on the program. We have spoken extensively on why women should go to antenatal, why they should give birth at a health facility, why they should, even after giving birth, they should come back for a routine check.
Yes.
And equally, the child giving birth to needs some form of immunization to keep the child afloat.
Exactly.
Thank you so much for your time with us.
Thank you. Thank you very much for having me.
All right, viewers, that's the much we have on this discussion program. We'll be looking at the status of reproductive, maternal, and child health in Nigeria, and of course, the country director, Rotary Action Group for Reproductive, Maternal, and Child Health, Rotary RMCH, Professor Emmanuel Lufadiju, have done justice to this subject matter. We hope that the statistics will be reduced by your deliberate effort to visit and give birth in hospital. Thank you so much. Until I come your way again,